My name is Anuja Patil and I'm one of the anesthetic registrars in West Midlands Deanery. I'm currently working at the University Hospitals of Coventry and Warwickshire. I'm going to discuss a quality improvement project that we did in our trust about awareness about anaphylaxis amongst midwives. So we all know these pictures as anaphylaxis, and as anaesthetists we know how to identify it and how to treat it. But do the ward staff know how to identify it and how to treat it? Do the midwives know how to recognize it? The trust had 11 cases of anaphylaxis in 2013, and 2 of them were on the labour ward. After analysing the clinical adverse events, we found out that there was a definite lack of knowledge about the condition amongst the midwives. So we decided to do this project, and our main aim was to assess the extent of the problem, to provide training based on the guidelines given by Resuscitation Council UK, and to reassess after we've provided them with the training. So we conducted an electronic survey, and an online response collection tool, SurveyMonkey, was used. It was sent to 210 midwives by midwifery training facilitator. We did the survey in 3 stages. In stage 1, the midwives were presented with a clinical scenario about a pregnant woman developing an anaphylactic reaction to antibiotic at 2 o'clock in the morning while the anaesthetist and obstetricians were busy on the labour ward with an emergency section. They were expected to answer questions which involved identification, knowing symptoms and signs, knowing what is the first line treatment, how much is the dose of intramuscular adrenaline, and where to find the anaphylaxis box. Now these boxes were introduced in the trust just before we conducted the project, and that's the reason we included that. After analysing the results, we found out that there was a definite gap in the knowledge, and we presented them with the teaching. An e-learning module was sent to them in the form of PowerPoint presentation. In stage 3, which was post-intervention, we reassessed the knowledge by a very similar clinical scenario and compared the results. So we got 155 responses in stage 1 and 116 responses in stage 2. And as you can see, there is a definite improvement in knowledge regarding first-line treatment, dose of intramuscular adrenaline, and the location of anaphylaxis box. And these results were both clinically and statistically significant. So why did we choose this survey? As we all know, anaphylaxis is a rare but significant complication of intramuscular, intravenous, or even oral drug administration, or it can be because of any other allergens. When it occurs in pregnant women, it's not only the mother, but also the unborn child, which can have significant harm. The incidence of anaphylaxis in pregnant women is not exactly known, but it's estimated to be about 1 in 30,000 pregnancies. The UK Obstetric Surveillance System recently collected the data on uncommon disorders in pregnancy, and anaphylaxis was one of them. NAP6 is coming, and NAP6 will be collecting the data about anaphylaxis during general anesthetic. It being such a rare or significant event, its knowledge and treatment by all the staff members is also one of the requirements for the hospital's CLST, hospital insurance purposes. We conducted the survey electronically as it was quicker and cost-effective way of collecting responses. It is accurate because the respondents directly enter their results or their answers into the survey rather than surveyor then transferring the answers into an Excel sheet. And it is also quicker and easier to analyze the results. We provided the training in the form of e-learning module, which is time and cost effective. It's flexible because the learners can cater their learning according to their own learning styles and pace in their own time. It is also consistent because the teaching that is provided by e-learning process is the same for all the learners, and it kind of takes away the teacher-to-teacher variability. We are aware that we will not be able to get 100% results, and we were unable to get 100% response rate. And it could be because some learners still prefer the traditional way of learning or traditional way of teaching in the form of face-to-face teaching or the classroom teaching. So we have achieved a significant improvement. We've proved that acting upon a local clinical adverse event done in a proper way can lead to significant improvement. So change is possible, and when it comes to patient safety, after knowing that there is a problem, doing nothing is unwise. Where do we go next? Our aim will be to maintain the current standards that we've achieved and also to provide further training. Anaphylaxis and its management is going to be incorporated as one of the stations as for the midwives' mandatory training in the trust. We're also going to extend the survey to the whole trust to know how much the ward staff know and what their knowledge about anaphylaxis is. Thank you very much.
Any questions?
Thanks. Can I start things off? Thanks very much for that. You had two questionnaires, one before and one after. How do you know that those questionnaires were equivalent and that the second questionnaire wasn't just easier than the first?
We presented them with the similar scenario. The scenario was the same. In the first survey, we included the questions about their identification of anaphylaxis, how to treat it, what is the first line treatment in terms of adrenaline dose, and we did say that would they like some more training about anaphylaxis. In the second survey, these 4 or 5 questions were the same along with the scenario, and we also included the questions about anaphylaxis identification, what tests should be done, and how would you discharge the patient from the ward. So the survey was similar, the questions were similar, and the 4 or 5 questions which we compared were similar.
I'm not sure if this is actually, I don't think this was working.
Just on a similar theme, how do you know that those people who responded, because your response rate was significantly lower the second time round, how do you know that the people who answered the second time round were there was bias towards that? Maybe they were the people who actually gained from the e-learning, and if you actually had a response from everybody, your figures might be significantly different.
That is one of the drawbacks of e-learning. Now, electronic survey is good for collecting the responses, but it's difficult to know as it is anonymized to know who's answered and who's not answered. So yes, that's one of the drawbacks.
Just out of interest, did you happen to survey the doctors on the ward at the same time to see the percentage of them knew where the anaphylaxis box was, or what the dose of adrenaline was?
Most of them knew it.
Okay. Thank you. Any other questions? Okay.
Good afternoon, my name is Rick and this is Natalie, and we're both going to be talking about a common cause of seizures in pregnancy that came into our emergency department at Mid Yorkshire. So I'm going to start off by introducing the case. It's a 35-year-old lady that's previously fit and well, came to the emergency department at 28 weeks of gestation. Her pregnancy was normal to date. She was not meant to have hypertension. She had one previous pregnancy that was delivered by caesarean section. She came with 2 generalised tonic-like seizures, each lasting approximately 1 minute, and they were self-terminating. Her symptoms prior to this were headache, visual disturbance and memory loss with amnesia of the pregnancy. On examination, her major systems were all normal. She was normotensive, there was no peripheral edema, she was febrile at 38.4 degrees, urinalysis showed proteinuria. On normal systems examination as well, there was no focal neurology. So we gave some consideration to the diagnosis. So obviously anyone that attends with fitting in pregnancy eclampsia is high on the differentials. She had proteinuria, and although she was normotensive, it was decided to give her magnesium in line with the local protocol. Then we considered epilepsy. Epilepsy is actually a common first presentation in pregnancy, but it can also be present in people that are known to have epilepsy. About 15 to 30% increase in seizures during pregnancy, and this is due to decreased compliance with medication, but also altered pharmacokinetics of medication in pregnancy. About 1 to 2% of patients will present in status that obviously needs aggressive treatment. Because she was febrile, we also considered infectious causes, we treated meningitis with ceftriaxone. And also we considered structural abnormalities such as intracerebral hemorrhage or ischemic stroke or space-occupying lesions, and so we arranged for a CT. All the other causes are listed but are not really directly relevant to our patients. So we arranged for a CT of the head that showed a lesion in the right temporal area and the left parietal area as indicated by the arrows. This was relatively nondescript, so she subsequently had an MRI that showed her to have 2 and multiple cavernous hemangiomas, which have bleeding points. Just illustrated just there. So she was subsequently diagnosed with multiple cavernomatous disease with focal epilepsy. She was started on Keppra, and she was jointly managed with obstetrics and neurology, and was then delivered by caesarean section at 39 weeks with combined spinal epidural. So Natalie's now going to discuss cavernomas and epilepsy.
So cerebral cavernomas are a cluster of abnormal blood vessels that occur around the brain, the brainstem, or the spinal cord. And they consist of multiple caverns of slow-flowing blood. They're also known as cavernous angiomas, hemangiomas, and AVMs. They occur in approximately 1 in 200 of the general population, although the presentation with symptoms is generally less than this, at about 1 in 400,000. This is due to the fact that most patients with a cavernoma do not present with symptoms and they're actually picked up incidentally on a CT scan. General population bleeding risk is approximately 1% per year, but this increases threefold in pregnancy, so the chance of getting symptoms in pregnancy increases. The cause of a cavernoma is unclear, but there may be a genetic link, so it may be passed down through families. And in fact, our patient is about to undergo genetic testing. There have been several case reports of cavernomas mimicking pregnancy-related seizures, so it has been advised that if patients present with seizures in pregnancy, particularly if there are atypical features such as our patient, that imaging with a CT scan plus or minus a subsequent MRI would be appropriate. Management of cavernomas is on a case-by-case basis depending on the symptoms. With our patient, she presented with seizures, and in this circumstance, anti-epileptic drugs is appropriate. However, analgesia for headaches or neuro rehab for any numbness or weakness would be appropriate if those were the symptoms present. Neurosurgery can be considered for these patients if the bleeding risk is deemed to be high. However, this is rarely required. So, epilepsy is a high-risk condition in pregnancy. And it is topical at the moment due to the recent Embrace UK report which came out last year, looking at 2009 to 2012. In this report, neurological disease was the third most common cause of maternal mortality, with approximately 50% of those deaths being due to epilepsy and the other 50% due to stroke or intracerebral hemorrhage. There were 14 deaths in total due to epilepsy, with 12 of these deaths due to SUDEP, which is sudden unexpected death in pregnancy, and the other 2 due to drowning during a seizure. Mortality in epilepsy is increased during pregnancy compared to the general population, and worryingly the mortality statistics haven't improved on these triennial reports from the initials when these reports first started back in 1985. So epilepsy care has therefore been highlighted in the report as an area that needs to be addressed and improved, particularly since in 10 of these 14 patients it was identified that changes to their care could have improved their outcome. So there were some key recommendations that were outlined, and these are listed on the slide. The bottom ones that are in grey are clearly important to all epilepsy care patients, however weren't directly related to our patient in this case. However, avoiding lamotrigine, as this is associated with maternal death due to its altered pharmacokinetics in pregnancy, and joint care between obstetrics and neurology were done in our patient as following the recommendations. So in summary, all patients who present with seizures in pregnancy should have a consideration to the differential diagnosis, including some unusual diagnoses if there are atypical features present. Cavernomas are a rare cause of seizures in pregnancy, and patients with epilepsy are high risk during their pregnancy and should be managed as such. And in view of the recent report, we can expect some new guidelines to be coming out in the near future. Thank you very much. Then we'll have any questions.
You said carcinomas may be in the brain or the spinal cord. Did your patient have any imaging of the back to see whether there were any present there before the CSE was done?
She didn't go on to have any further imaging, no. It was felt that she was asymptomatic from a spinal point of view, although albeit there may be further cholangiomas down the spinal cord which can be asymptomatic. But she did not have any imaging of the spine, she just had the imaging of the head.
Hello. Hello, I'm Dr. Horn. I'm one of the trainees in the East Yorkshire region. And I want to tell you about a project I did looking at the levels between insert or epidurals on the labour ward. Before I start, I'd like to reference Dr. Chamberlain, who's another trainee in the area. He helped me with the literature search. He can't be here because he's on night. And also give thanks to Dr. Vipond, who was a wise head to go to when we have any questions about it. So I'm going to start with a story, so I hope you're sitting comfortably. It was a dark, dark night on labour ward. Well, actually, it was a fairly normal night on labour ward. And all I was asked to do was put an epidural in a young, fairly fit, slimish lady who had no problems with the back and should have been fairly straightforward. And I went forward, did the usual consent, tried to put the epidural in and couldn't get it in. Had a couple of goes, just kept hitting the bone, couldn't get in, couldn't understand it, but it's one of those things. Now my consultant was just finishing their evening list upstairs, so before they went off home I asked them to come and try and place this epidural, which they kindly did. And to my great delight, got it in first time without making it looking remotely difficult. And I was, not too upset by this, but I thought I'd better get some feedback, get some advice on what they think went wrong. And they said, oh, you're putting your epidurals in far too low. That's something like L34 or something. It should be way higher than that. So being a good trainee, I went away and reflected on this and reflected that crazy talk. Everyone puts their epidurals in at L34. What on earth were they talking about? But just to make sure, I went and spoke to a few colleagues, and they all said, oh yeah, L34, that's where you put an epidural in. But some of the consultant colleagues I was with said, oh no, yeah, I put them in much higher than that, sort of L12, maybe even T11, 12, something like that. I thought, this is a bit strange. And they seem to be a little bit older than older consultants. That's not politically correct. Vintage consultant. Oh, that's worse. Anyway, so I thought maybe this was, a pattern, and what I should do is put together a little project to look at whether the more recently trained anaesthetists are putting their epidurals in lower than those who've been trained a little bit longer ago, shall we say. And then I would look at the literature, find out where we should be putting them, and feed it back to good people now. So that was my aim, and what I did was form a simple survey. And I asked colleagues in the local region how long they've been since they've been trained in anaesthetics, how senior was, whether they were specialists in obstetrics, and also what vertebral level they ideally placed their epidurals in. And then I looked at those results to see if there were any links between how long you've been practicing and where you put them. And then we did the literature search afterwards. So, if I can show you the results, feel free to have a good look at them, but I'll draw your attention to these two here, which show that if you've got less than 10 years experience, you're 3% of them only actually put their epidurals in above the L2 vertebra, sort of the high lumbar area. Whereas when you've been around for working for more than 10 years, that number rises to 23%. And there's similar-ish patterns with whether you're a specialist in obs, whether you're a consultant versus a trainee, things like that. And indeed, if you look at specialist obstetric consultants of more than 10 years, you get up to sort of 36%, so it's getting to quite high proportions. And when you look at this statistically, analyse the statistics, it's actually a statistically significant increase, probability 0.017. So there is a link there. So it was clear what was happening here. About 10 years ago or something, some evidence came out which said we should be putting our epidurals in at L34, and those vintage anaesthetists haven't changed their practice yet and haven't caught up and they're resisting. So I went to look for the literature to find this evidence. So two investigators, Dr. Chamberlain can't be here, independently searching, trying to identify any evidence to suggest where we should be putting these epidurals. PubMed, Medline, Google Scholar, everything we can look at really. And in total we found no evidence. There is one paper in 1980 which said that morphine uptake systemically is slightly higher in lower lumbar, and so maybe lower lumbar epidurals aren't so good for that reason. That was it, and that's not really relevant to what we're looking for here. So there's no evidence out there. And it was interesting, Dr. Wilson earlier talking about an evidence gap. This is an evidence gap. We don't actually know what level we should be putting them in. So what's going on here? Well, yes, there is a link. The less experienced anaesthetists in our area put their epidurals in lower than the more experienced colleagues. We don't know why, and it certainly doesn't seem to be based on evidence. There was a free text box at the end of my survey for people to put in freehand why they aim for the level they aim for. And those who inserted their epidurals higher were citing things like first stage of labour goes through the T10L to L1 nerve routes. So those are the ones you want to be focusing your pain relief on. Whereas the L34 group was saying, oh, it's safer. If you go in too far, you can't hit the spinal cord. It's also easier, it's where we go. But there were a significant number who said, oh, I never really thought about it. You put them in an L34, that's where I was trained to do them, that's where I do them. So, and finally, there were a militant group who said, you really should be going higher. It's better for the first stage of labour, as I've described. It's also better in second stage. Lower number of epidurals, too much numbness. They can't push, they can't coordinate. And also, if you want to top up a section, it takes longer. Really strongly held belief from some people that we should be aiming higher. Again, no evidence to support it. So, well, I can't stand here and tell you to stop doing whatever you're doing and change to whatever I tell you to do. There's no evidence to back it up. However, I do think that we should be aware that there isn't clear evidence of what level we should be aiming for. And trainees should be aware that there is an argument from the more experienced colleagues that perhaps we should be aiming a little bit higher with our epidurals. And I think we found an evidence gap. We need to be looking at doing a randomised controlled trial comparing upper lumbar epidurals to lower lumbar epidurals. And that's the end of my project. I'm very happy to hear some opinions. There's probably, maybe even a militant person here who really believes we should be aiming lumbar. It would be great to get their comments. But if anyone's got any thoughts or questions, I'll be very keen to hear them.
If you were going to have a randomised controlled trial, given the significant variability between imaging and what space people think they're at, would that not necessitate having ultrasound image directed?
That's fed right into the whole day, really. Yeah, I mean, ultrasound would be the obvious way to confirm what level we're putting them in, and that seems to be a growing development in the specialty and something we can probably do in most centres now. I think an RCT does have, issues with coming up with it. I mean, consenting a pregnant woman who's screaming for an epidural is obviously something we struggle with for research in obstetrics anyway. But probably not insurmountable. The numbers you need as well will be quite high, so probably something like the Anaesthetic Audit Research Matrix of Yorkshire, or SHARC is the southern one? The southern one, because only Yorkshire exists. So something like that might be some way of getting it across a multi-centre, but yeah, I think there are a few issues that we'd have to iron out to develop that. Can you wait for the back? I can't hear you.
Most hospitals will have an epidural database nowadays. You can look back on the data for which point, how many number of people put it in higher levels and how many put it in lower levels. And you can see the success rates directly.
You absolutely
most
can.
Most would have the data for the last 15 years or so.
You
have thousands of cases on the database.
You absolutely can, but the problem is you get a lot of confounding factors with that, because the people who are putting them in higher tend to be more experienced.
Yeah.
So that's going to produce all kinds of confounding things. They're coming in, probably they're doing the second attempt when the trainee can't get in because they're the senior consultants. Or
what I'm trying to say is there will already be thousands of cases on the database.
Yeah.
Do that sort of research in a prospective manner. You'll take years
and
years.
Yeah, you could do it prospectively, but as I say, if you leave it to people's choice, then you'll get confounding factors from the types of people who are naturally doing higher epidurals and lower epidurals. So I think the problem would be, I'm not sure the results would be interpretable as as giving you the final answer.
It's just because people say it's a certain level, it's not necessarily that.
Absolutely. Absolutely. If you're going to try and do it by level, you need something like ultrasound.
Sorry, what was your who did you ask? Where did you ask?
Where did you ask these people?
Well, you were one of them, Dr.
I've never met you before in my life.
I'm trying to remember, were you the man who came and put it in the first time?
I'm sure.
Or Jim, I guess.
Yeah.
It was York, Hull, Scarborough.
Yeah, I generally think, and this is not being this sentimental, but there's recently retired obstetric consultant anaesthetist Tamara Madej, and she was very strong on what, she does all acute pain, and if you put it in at this level, it would go on, didn't work down there, put it there. She was absolutely obsessed by what level it was, and she's written in her guidelines in York. I tend to put them in lower thoracic, and it trickles down. I can remember hearing her say that. So we might have all just been subliminally influenced by her.
Yeah.
I'm sure I was that man, actually.
I think it's a problem. I'll not name check anyone, but you've referenced it.
I've got a theory about why this is. Because when I first started being taught how to do lumbar epidurals, I was taught to put my hands on their haunches, and that would be L3-4. And as the patients get fatter, my hands seem to go higher up. I'm sure by the time I finish my career, I'm going to be putting epidurals in at T8.
It'll work then.
I hope so.
That'd be an interesting way of doing the study, see if you got better as you went on, but I suppose there's other confounding factors for that as well.
Do you think there's any chance that it's that the more senior trainees and consultants have more experience with thoracic epidurals, and they're just generally more comfortable? My practice changed when I realised that you could go quite high in the back and it didn't cause problems. So I started leaving myself more space below the epidural for potentially a spinal later, and realising it was okay at L1-2 and it still works, and it's not unsafe. But it was related to being more comfortable with thoracic epidurals, which obviously junior trainees won't have as much experience of.
And definitely people were citing, I'd rather go L3-4 because if I go too far, the cord's finished, it's a bit safer, I just feel like I'm not going to cram their spinal cord. So as you get more comfortable doing them in the danger zone, you are in the longer term. So absolutely.
Hang on, BJ.
Was it the first attempt, the senior anesthetist?
Sorry?
Was it the first attempt on that patient by the senior anesthetist when they are doing the higher level? Because lots of times the juniors must have put lots of holes in the few levels, so they go straight to the topmost level.
Yeah, you're probably right. Yeah, once you've been there 10 years, by the time you get to the back, they've all got so many holes in L3-4, you can't hope to get in there. Yeah, maybe. Having not been a 10-year-long consultant yet, I can't tell you what it's like, but I'm sure that's a factor.
If there's no other questions, we should probably just break slightly early for tea and coffee. So.